So, Sadeer, you were the medal lecturer this year. And listening your talk, I was impressed because you clearly described the evolution of the triple procedures with the time. Can you say shortly to our audience now?
Thank you, Enzo. It was a true pleasure to be here at SICSSO in Pestum in southern Italy. Thank you for your hospitality over the past many years. It's a great meeting to come to and be with colleagues from Italy and from around the world. So many countries were represented, talking about ocular surface disease, management of ocular surface disease, as well as different techniques of keratoplasty. My mission as the medalist speaker was to discuss the evolution of the corneal triple procedure over the past 3 decades. Specifically, I was discussing how the combined procedure between keratoplasty and cataract surgery has changed over time. So we started out 30 years ago doing a full thickness corneal transplant with all the challenges of open sky removal of a cataract, implanting the intraocular lens, and dealing with the potential complications of posterior pressure. We fast forwarded 10 years when we stopped doing that and we started doing phacoemulsification through the incision, through the phacoincision, putting an implant, constricting the pupil, and then doing a full thickness graft. And then once endothelial keratoplasty became available to us, the procedure changed altogether. We now had a procedure that we can do more safely and more predictably. So we started doing Decimate stripping automated endothelial keratoplasty with cataract surgery. And the latest, of course, is doing DMEC, Decimate membrane endothelial keratoplasty, combined with cataract extraction with intraocular lens implantation, which is a very exciting procedure both for the surgeon and for the patient, as well as a quicker procedure that leads to quicker visual rehabilitation. Now, DMEC combined with cataract surgery can be done in different ways. It could be a classical triple done at the same time, or it can be staged, just like we could have staged other keratoplastic procedures. There are some advantages to staging the procedure, of course, either doing the cataract first or doing the DMEC first. But many times when the cataract and the corneal endothelial dystrophy are significant, it's nice to do them in a combined manner. So that was my mission, and I hope I was able to make a small contribution to an incredible Congress. Thank you very much.
Oh, your contribution was no small, but because, as you say, you are an educator, we want to enjoy another question to you. May I?
Of course.
So can you say something about EK? Why do you prefer DMEC or DSEC, and when do you use DSEC and DMEC, just to share with the others your point of view in a discussed problem?
Yeah, so I have a lot to say about that, but here's what I always tell colleagues as well as our residents and fellows. I say you cannot argue against a procedure unless you did that procedure itself. So if you are strictly a DSEC surgeon, you cannot say it's better because you don't have experience with DMEC, and vice versa. If you only do DMEC and you don't do DSEC, you cannot make an intelligent argument for one over the other. But if you do both procedures, then you know the advantages. DMEC clearly gives quicker visual rehabilitation and frequently achieves a visual endpoint faster and to a better level than with DSEC. But DMEC, at least the current way of doing DMEC, which is unscrolling tissue by tapping maneuvers and anterior chamber shallowing maneuvers, may not be appropriate for all patients. So for cases that have comorbidities, for patients that have tube shunts, filters, post-vitrectomy, anterior chamber intraocular lens implants, or a communication between the posterior segment and the anterior segment, like sutured posterior chamber implants, I still prefer to do DSEC. One day, as our DMEC techniques get so much better, we may be able to offer DMEC for all patients. And the truth is, as Dr. Holland from Cincinnati showed, an ultra-thin DSEC is almost as good, if not equal to DMEC, 6 months after surgery.
And what about rejection, endothelial cell loss, and tissue survival?
So, excellent questions. Obviously, you know the answers, otherwise you wouldn't be asking them. So the issue right now is the following. most of us feel that the rejection with either procedure is low, less than 10%. The issue, the advantages of DMEC is that you are basically presenting the eye with a lower antigenic stimulus. So in principle, the rejection is going to be less. You're going to be keeping them on steroids for a shorter period of time. And especially if they develop a steroid-induced pressure elevation, you have a better way to manage it than with DSEC, where if you stop the steroids earlier, the rejection may increase. As far as cell loss, again, it depends on how comfortable and how experienced the surgeon is. I think in my hands right now, having done DSEC for 12 years and DMEC for only 5 years, my cell loss with DMEC is still higher than with DSEC. But of course, my rebubbling rate is also higher with DMEC. With DSEC, our rebubbling rate is now under 5%. With the DMEC, our rebubbling rate is closer to 10%, sometimes higher, only because I will rebubble earlier if the graft is not completely attached. Because as you know, with DMEC, frequently the graft is not completely attached many times, and instead of waiting for it to attach using the 1/3 rule that we were taught many years ago, I will rebubble earlier, because they get better so quickly if you rebubble early. So therefore my rebubbling rate is higher.
Okay. May you say goodbye to everybody and moving to DMEC?
Well, I will say, first of all, that I encourage every surgeon who is serious about endothelial keratoplasty to acquire the skills required to do DMEC. I would like to say that the last 3 days at SICSSO have been wonderful. It was a unique opportunity for learning and teaching and sharing thoughts with colleagues. Anybody who wants to be around a few hundred dedicated corneal surgeons, there's no better place in the world to find that than SICSSO. So we look forward to seeing you all in Turin next June 2019. Thank you very much.